welcome to cardiac surgery, and move.
Thank you very much. Good morning, everybody. So I'm going to run through the trials that you need to be aware of that the guidelines are based on. If this computer works. So when I was a trainee in Birmingham, the equipment was much better, the organization was much better. I don't know what's happened, the standard.
I won't tell the story about the seat.
This is not moving. It's not moving.
I'm going to sort it out for you.
Okay, so you're all aware of the three trials that were done in the 80s, the European trial, the Veterans Association trial, and the CAS trial. And these trials in the 80s showed that coronary artery bypass surgery is better than medical therapy. Following on from that, there was a systematic review by Youssef et al. Published, I think, in 1994. I need my slides. 1994, which included 7 trials, including the 3 trials, and that confirmed also that if you have severe coronary artery disease, multivessel disease, that surgery is better than medical therapy. That surgery is better than medical therapy. And since then, published in 2014, there's been a meta-analysis of 100 trials. And this showed that CABG improves survival when you compare it with medical therapy for coronary artery disease. So we know that coronary bypass surgery is better than medical therapy. What about patients for heart failure? And to answer this question, you need to know about the STITCH trial. The STITCH trial was initially reported in 2011, and it showed that CABG, as you can see in the graph, affords you better survival than medical therapy. And this was up to 6 years, but when they followed up the patients to 10 years, this was also persistent. And at 10 years, CABG significantly reduced all-cause mortality in patients who have coronary artery disease with ventricular systolic dysfunction. Is all revascularization good for heart failure patients? No, because this trial showed, the PCS2 trial, which was reported in 2022, that PCI does not have any advantage to medical therapy when it comes to patients with heart failure. And we're currently running a trial in the UK, you might be aware of or be involved in it, PCS4, actually comparing PCI versus coronary artery bypass surgery for patients with impaired heart function. What about coronary artery bypass surgery for patients with multivessel disease? The initial trials at the top in grey compared PTCA with CABG, and CABG was winning all the time. Then the cardiologist said, oh no, we have a new thing called bare metal stents, let's compare it with CABG. They did multitude of studies, the same thing. The composite outcomes was always better for CABG versus PCI in multivessel disease. And then we moved into the era of the drug-eluting stents. And the first major trial that reported was in 2009, the Syntax trial. And this showed that, which was reported in 2009, as I said, it showed that the rate of events was much higher with PCI, 17.8% versus 12.4% when compared with surgery. And they recommended that surgery remains the standard of care for patients with 3-vessel disease or left main coronary artery disease. That was the conclusion initially. But, and as you can see, this is the graphical representation of that result, with CABG having better outcomes than overall outcomes than PCI. But when they followed up the patients for 10 years, and this was reported later on in 2019, they reported that there was no significant difference in all-cause mortality between PCI using first-generation drug-eluting stents and CABG. But CABG still proved a significant survival benefit in patients with 3-vessel disease, but they now removed left main stem from that benefit. So that was the 10-year result from the syntax trial. I'm not going to go through the syntax score. You should all be aware of what the syntax score is, how to calculate it, what does it mean, and the significance of the syntax score, which came from the syntax study. It's basically an estimation of the severity of the coronary artery disease, and you have to go through each lesion and give it a figure, and you add a score at the end, which has an impact. But it has been shown that the syntax score actually is much more of an independent predictor of long-term MACE and deaths in PCI than in coronary artery bypass surgery. But it is used now in the guidelines as a discriminator for which way the patients go, whether to go for surgery or for PCI. Another study that looked at multivessel disease was the BEST trial, and this reported at 2 years and at 4.6 years a much better survival benefit and lower complications rate with coronary artery bypass surgery versus PCI. This was reported in 2015. Okay, so that's triple vessel coronary artery disease. What about left main stem? And this is where it gets a little bit interesting. So the first study that reported about left main stem disease was the Nobel trial in 2016. And it showed that after randomizing 1,201 patients, that patients with significant left main stem disease with a mean syntax score of 23 do better with bypass surgery than with PCI. But then came along the Excel trial, which caused a lot of controversy. And this trial randomized 1,905 patients with significant left main stem disease, and at 3 years follow-up, they reported that there was no difference between PCI and CABG for left main disease. And this is the graphical representation of the outcomes. And you can see here that there was a lot of initial events that were not taken account of in the Excel trial, and we'll get back to that point again. And also then the Excel trial followed up their patients for 5 years, and they still persisted with the same conclusion that there was no significant difference between PCI and CABG. Do we believe the Excel trial? The criticism of the Excel trial was run by Abbott. It was industry sponsored. They designed the protocol. They selected the centers. They managed the trial. So it was totally controlled study. There was hesitation to enroll severe left main stem and multivessel disease in the study. Only 5% of the eligible patients got enrolled. And unfortunately, the conclusion did lead to increase in the management of left main stem disease with PCI. But there was other problems with with the Excel study. They did not look at peri-procedural AMIs either. And also, as the study progressed, they changed the definition of an AMI. So there was less AMIs reported with PCI because of the definition had changed. So in response to all that, the criticism of the Excel trial, and because the guidelines had based in 2018 were based on the Excel study, and had put left main stem management with PCI as class 1A evidence, there was the joint statement by the European Society of Cardiology and AACTS in 2022, who reviewed all the evidence, the Excel trial and the other trials, and they actually recommended a change for PCI with left main stem disease to 2A rather than class 1. What about diabetes? I think there is no argument with diabetes. Even the most ardent cardiologist, we don't have one here, even the most ardent cardiologist believes that triple vessel coronary disease or even double vessel coronary disease with diabetes, they are better served with bypass surgery over PCI. And the first big evidence that we have is the FREEDOM trial reported in 2012, and that showed strong improvement with outcomes for PCI, for CABG versus PCI. And that continued up to 8 years when they followed up their patients on the course. There's been meta-analysis of other 4 studies, and that has shown the same results, and pooled results of 11,518 patients also showed the same thing. So with diabetes, there is strong evidence for coronary bypass surgery. I'm just going to finish with mentioning a few things about how do we decide on the severity of coronary artery disease and the concept of FFR. You should all be aware of that, when to request it and how to request it and how to use it and what's the impact of it. And it has been shown in this study from 2009 that FFR guided PCI does actually improve outcome. So by extension, you could think that FFR guided all revascularization, including coronary bypass surgery, may benefit outcome of the patients. And this is also shown on the long term of 5 years follow-up. And the newer measurement is and you need to be aware of this, is the instantaneous wave-free ratio, IFR, and this has been shown to be similar results, if not better than FFR. So you might get your cardiologist reporting to you the FFR was positive or the IFR was positive. You need to understand what it means and the significance of that in defining the severity of coronary artery disease that you need to deal with. And these are the figures that you need to know off the top of your head. If they say the FFR is below 0.8, you need to treat the patient. If they say the IFR is below 0.089, you need to treat the patient. And I'm sure all this will be discussed later on in the interactive sessions. So this is the latest guidelines that was there in 2018, and you can find a copy of this. In the majority of conditions, surgery is indicated as Class 1A in Class 1A evidence with proximal LAD stenosis, with proximal LAD stenosis in 2-vessel disease or 1-vessel disease, left main stem disease. As we said, it was Class 1 evidence, but if you replace that with what the consensus statement came out with, it's not a Class 1A evidence for PCI for left main stem. It should be Class 2A. Okay. Triple vessel coronary disease and patients with diabetes, as we said, surgery is the best option for these patients. So in conclusion, what favors CABG? Diabetic patients, reduced left ventricular function, contraindications to dual antiplatelets, recurrent diffuse instant stenosis, high syntax score of greater than 23, anatomy likely resulting in incomplete revascularization with PCI, and severely calcified vessels that limits the expansion of the lesions when the stents are employed. Thank you very much for listening.